and then I'll send this out to folks afterwards.
Okay, great. Welcome, everybody. We'll give folks the few minutes to hop on. All right, welcome everybody. It looks like folks are still hopping on, but I know we have a lot to cover today, so we might go ahead and get started with introductions. We are also recording this session so that it can be available for folks who weren't able to make it here today in person. I'm Rosie Nevins-Aldifer. I'm the Director of Quality and Compliance at HCRS, and for the last year, I've been working on the CCBHC Certified Behavioral Health Clinic project, which is a grant. There's a few different pathways to becoming a CCBHC, but the current one that HCRS has embarked on is to receive a grant directly from SAMHSA and the federal government to become a certified community behavioral health center, which helps us expand services, helps make connections with other community partners in the area that perhaps we did not have the resources to do in such a seamless way before as a community. It's given us some funding to be able to really do some deep digging into community needs, which is what we're going to talk about today. Probably most folks in this room know there's many community needs assessments that occur in our community. However, this one is very specifically mental health and substance use focused, which we're really excited about because those two are always highlighted on all the community needs assessments as top needs in the communities that we live and work in. So with this project and this funding, we were able to dig a little deeper into that and are very excited to be able to present with you the results of that work today. So I'll hand it over to George Karabakakis to give just a little bit more of an introduction. And then we're going to hand it over to Ali Netto, who is our CCBHC project evaluator. And she has a wonderful presentation for you all. Just by way of housekeeping, I will be monitoring the chat. So if you have questions throughout the presentation, we're going to try to hold on answering questions until the end. But feel free to drop them in the chat and I will just work my way down once we get to the Q&A portion. Or feel free to save your question and you can raise your little yellow Zoom hand if you like at the end and let us know. So welcome and over to you, George.
Okay, well, thank you, Rosie. And for those of you who don't know, I'm the CEO of HCRS. And yeah, this was quite an undertaking. And I think it's just so important. It's so valuable to hear from folks in our community, particularly individuals that have been historically marginalized. It's just so essential as we move forward in terms of developing this, our certified community behavioral health center. And I want to thank Rosie and Victoria and Allie and of course Anne and so many others who were part of this process. And so I just want to extend my appreciation. And without further ado, I think we should just jump right in. And Allie, you want to do that? Thank you.
Sounds good. Thank you, George.
It's all yours. Yeah.
Thank you. Hi, everybody. Welcome. As folks gather, my name is Allie Netto. I am the CCVHC evaluator here at HCRS, and I'll be running through today's community needs assessment presentation. Just for folks hopping on now, and if you have other folks in your organization who are interested in this presentation, we are recording, and we will make this available for folks. All right, so I'm gonna share my screen and we'll jump right in. All right, and can folks see me? Can see my screen all right?
Looks great, Allie.
Thank you. All right, so thank you everybody for joining us to learn more about our findings from HCRS's Community Needs Assessment. This was done as part of HCRS's effort to achieve Certified Community Behavioral Health Clinic status, or CCBHC, from the Substance Abuse and Mental Health Services Administration, or SAMHSA. A research company from Boston, the Institute for Community Health, also participated in the research and helped us collect data. And just a little note before we really jump in, if you're viewing this presentation on a phone screen, you may have to toggle a bit in order to view the entirety of the slide. The presentation is best viewed through a laptop or desktop. And then if you have, then for today, we do ask that folks hold your questions until the end, but feel free as I go throughout, if the question comes to you, please feel free to drop it in the chat. Great, so during today's presentation, we'll review the focus areas and goals of the needs assessment, provide an overview of the data collection activities, look at community survey demographics and the different types of providers who participated, review our key findings, and then we'll wrap up with a summary. Great, so our needs assessment focused on 5 different areas. The first one was meaningful involvement of community members. Then we looked at social needs, such as transportation, food, housing. Then we wanted to take a look at collaboration and care coordination, linguistic and cultural barriers to care, and finally, workforce capacity and training needs. Informed by our focus areas, 4 goals were developed. We wanted to first assess client and community factors that contribute to health. Then we wanted to understand client and community member needs and experiences with substance use and mental health services. We then wanted to understand how HCRS is and should be positioned in the regional mental health and substance use services landscape. And finally, we wanted to describe the experience and needs of providers in addressing mental health and substance use related needs. We implemented 4 main data collection activities from February through June of 2023. All of our data collection activities focused on community members who identify as people with lived mental health and/or substance use experience, and providers who access and/or provide services in Windsor and Windham counties. First, we launched a community-focused survey to collect feedback from people with lived experience receiving or trying to access mental health and substance use services. We then launched a provider-focused survey to collect feedback and input from mental health and substance use providers, as well as other community partners. We received 436 responses in total across both surveys, 243 from our community members, and 193 responses from providers and partners. In addition to our survey data, we also held listening sessions. 5 community listening sessions were held for adults with mental health experiences, BIPOC adults, LGBTQ+ adults, youth, and people active in their substance use. Additionally, 1 peer support staff listening session was held to gather feedback and input from individuals specific to these roles. We had 42 individuals participate across the different types of listening sessions. Now we're going to move on to the community survey demographics. 93% of respondents were actively receiving mental health services at the time of the community survey. 36% were receiving substance use services. 4% were seeking mental health services, and 8% were seeking substance use services. 54% of participants received services in Windham County, and that was the same percentage for Windsor County as well. And the percentage of folks who receive services in Windsor and Windham counties is greater than 100% because some folks reported receiving services in both counties. When we look at age range, a little over half of people with lived experience were between 25 and 44 years old. And when we look over at race and ethnicity, most participants, 83%, self-identified as white. The remaining categories represented 5% or less of respondents. Almost half of survey respondents identified as women, and 42% identified as men. 5% of folks identified as non-binary, and 3% reported that they have another gender, and responses included she, they, genderqueer, queer woman, trans man, etc. When we look at gender with more specificity, almost half of respondents identified as cisgender women. 42% identified as cisgender men. 6% identified as non-binary. 3% identified as transgender men, and 3% identified their gender in another way, and 1% identified as transgender women. When we look at sexual orientation, participants were largely heterosexual at around 62%. 14% identified as bisexual, 8% identified as asexual. Gay, lesbian, or same gender, pansexual, and prefer to self-describe all represented 5% or less across categories. When we look at household income, 38% of participants reported a household income of $25,000 or under. 19% of respondents reported household incomes between the $35,000 through $49,000 range, and the same was true for the range of $50,000 to $74,000. In terms of housing, 70% of participants reported either renting or owning their own home. 13% were staying with a friend or relative. 9% reported something else, and responses included living with parents, in dorm rooms, subsidized housing, and being homeless. And staying in a vehicle, emergency or drop-in shelters, hotel motels, and living with a shared provider represented 3% or less across the remaining categories. So now we're going to take a look at the different types of professional roles of providers who participated in our data collection activities. The graph here depicts the different roles. So 20% of providers were social workers, therapists, or counselors. And this was closely followed by administrative roles and case managers, both at 18%. The remaining roles represent 9% or less of provider respondents. A note here that 9% of folks identified as another role, which included folks who were in roles such as residential specialists, activity coordinators, area managers, department directors, employment specialists, health coaches, information specialists, pastors, and school nurses. Providers came from a range of different sectors. 66% were from the mental health service field. 26% reported being from another sector, which included developmental services, education and public school systems, community health, hospice and aging services, and nonprofits. Those in the substance use sector represented 24% of providers. 14% were in the realm of harm reduction, and 11% provided physical health care. The remaining sectors all had responses of 7% or less. Providers reported serving a range of different communities. The majority of providers, 80%, worked with people with mental health needs or diagnoses. 67% worked with people and or families with low incomes. 45% served people with developmental disabilities. 41% served youth. 32% of folks worked with the LGBTQ+ communities. 27% served people who identify as psychiatric survivors. 15% worked with BIPOC communities. 13% served immigrants, migrant workers, and or refugees or asylum seekers. And 6% reported serving another community. We had responses which included the elderly, at-risk children, formerly incarcerated individuals, and people living with HIV/AIDS. All right, so now we're going to move on to our key findings portion of the presentation. Our first key finding we'll review are community needs and barriers to care. Our first finding in this area is related to gaps in service for substance use and mental health. The percentages of people with lived experience who would like to receive services but are not receiving them, and of people with lived experience who are receiving services less frequently than they would like, are shown here. More than 30% of people with lived experience reported not receiving the services as frequently as they need in the categories of psychiatry, community support, groups, and peer support. 17% of people with lived experience reported not receiving any services in the area of psychiatry, community support, and groups, though they felt that this was something that they needed. In addition to service gaps, we also asked about challenges to access prescription medications. Almost half, 48%, reported challenges. The most common challenges reported were relating to affording prescription medications and getting an appointment with their prescribing provider. People who identified as BIPOC were significantly more likely to report some type of medication challenge than those who identified as white. People with lived experience who accessed or sought care only in Windham County were significantly more likely to report a prescription challenge than those who accessed or sought care only in Windsor County. When we spoke with people with lived experience and providers about barriers to care, many noted a lack of service availability in the region. Participants spoke about needing expanded hours or more flexible appointments, difficulty with waitlists, and a lack of providers in general, especially primary care providers and those who share their clients' identities, cultures, and languages. Youth with lived experience who participated noted a need for more mental health care facilities and providers specific to young people. Folks also mentioned that they could use support in navigating their insurance networks to find providers. Many participants also commented on social and basic needs being a barrier to care. Transportation, care that is closer to home, housing, food insecurity, and a lack of employment were the major themes which emerged. Many also spoke about how stigma and a lack of support from family and community can make it difficult to engage in services. When we asked respondents about service needs, many people with lived experience and providers supported more harm reduction services. We collected targeted feedback from providers and people who identified as active in substance use and/or recovery and/or had personal experience with substance use on the specific harm reduction resources that they would like to see in Windsor and Windham counties, and that is shown here on the two graphs. Overall, people with lived experience here on the left and providers here on the right often emphasized peer support and connection opportunities as helpful harm reduction resources. People with lived experience most frequently selected harm reduction peer groups and connecting with peers and friends, while providers overwhelmingly selected non-judgmental primary care and opportunities for peer connection. People with lived experience and providers also supported the need for more recovery supports. Similar to the last slide, these questions were asked of people who identify as being active in substance use or in recovery and/or who have personal experience with substance use. And so the folks with lived experience, their responses are on the left, similar to the last slide, and the recovery support priorities for providers are here on the right. The largest share of people with lived experience responding to the survey indicated that they would find accessible and affordable recreation options and medication-assisted treatment most helpful to their recovery, which was closely followed by spaces where they could go to connect with people with shared experiences and support for having basic needs met. Providers most frequently selected support for basic needs at 84%, which was twice the rate than those with lived experience chose. Providers also felt that a priority was accessible and affordable recreation options, which was 71%. The community survey also collected information about what types of support people with lived experience are looking for from their providers around their mental health care needs. Overall, the largest share of respondents, 59%, selected having someone to listen to me and getting relief from overwhelming feelings, distress, or mental health symptoms. This was followed closely by support healing from challenging or traumatic life experiences and support in the community. People with lived experience also commented on what support they would want during a crisis. 53% wanted moral and community support. 23% wanted mental health support from their providers, and 10% wanted to access crisis lines and response services. Others also commented that financial support, caregiving support, respite care, and inpatient hospital care would also be helpful to them during a crisis. People with lived experience who participated in the community survey and listening sessions mentioned looking for more support with meeting day-to-day needs. The largest share of respondents indicated that they are looking for support with advocacy around being treated poorly due to emotional distress, mental state, disability, or psychiatric diagnosis. Closely following was support navigating difficult relationships and accessing basic needs like housing, income, healthcare, transportation, and food. 35% of folks would like support with organization, such as remembering appointments or keeping their living space clean. And this was closely followed by those who would like support with navigating the world with a disability. All right. These are some direct quotes from community members with lived experience regarding community needs and barriers to care. I'll give folks a minute just to read these. I'm going to move on to the next slide. Great. So the next finding area we'll review is related to people's experiences with the mental health and substance use care service delivery system in Windsor and Windham counties. %80 of respondents indicated either that it was very overwhelming or somewhat overwhelming to manage their health care. People with lived experience who participated in listening sessions noted that encountering significant barriers and competing needs makes it challenging to manage their care. Providers also elaborated that experiencing multiple barriers to care, including unmet social needs and lack of service access or availability, can create difficulties in accessing and managing care. Peer support staff mentioned that engaging in an intensive intake process in order to receive services can also be daunting for people who have unmet needs. When we look at experiences with the local service delivery system, many people shared positive experiences. More than half responded that their providers were always supportive and always respectful. And 46% of respondents indicated that they always received services in a timely manner. People with lived experience also spoke about what makes accessing mental health and substance use services feel safe. The biggest 4 themes which emerged were having positive, supportive relationships with their providers, confidentiality and autonomy, having support from their families and community, and working with others who have lived experience. Here are some more direct quotes from community members with lived experience regarding local mental health and substance use care. I'll give folks a minute to read these and really let them stand for themselves. I'm going to move on to the next slide. So now we're going to take a look at key findings in the area of collaboration in the regional mental health and substance use services landscape. The major theme which emerged amongst providers is the need to strengthen existing partnerships and collaborations. 42% of providers identified the need to increase coordination between physical health care, mental health care, and substance use care to better support their clients. Providers had a number of suggestions to do so, such as having organizations increase their communication and community presence, hire more providers across sectors, having built-in time to coordinate across care teams, facilitating ROI and HIPAA releases, working to reduce turnover and hire care coordination staff, and addressing stigma and judgment. And our final key finding area looked at workforce need and experiences. Provider feedback overall reflected a strain on the capacity of existing providers in Windsor and Windham counties. Many emphasized the need for more providers and measures to reduce turnover, such as improvements in job quality. This feedback is reflective of national level trends in mental health and substance use care, where demand and need exceeds the capacity of the existing workforce. Participants stressed that lack of providers and workforce capacity impact both client care and service delivery, and the health of providers themselves. 39% commented that not having enough providers and high turnover gets in the way of community members accessing high quality care and also impacts stress and burnout amongst providers. Providers also commented that more providers and less turnover would also improve collaboration and coordination of physical, mental health, and substance use services. Many specifically commented on what was needed to improve provider experience, including reduced caseloads, more time to implement learnings from staff development trainings, and more time to spend on collaboration and consulting with others. Reductions in administrative burdens, more compensation, and safer working conditions were also themes that emerged. We also took a look at provider training needs and preparedness to serve different populations. The graph here depicts what providers identified as their training priorities amongst a list of 5 options. 75% identified LGBTQ+ training as their top priority, followed by people who use drugs, people who are unhoused, harm reduction, and racial equity and multicultural care. The table on this slide depicts provider preparedness to serve certain groups. The white columns depict people with lived experience on how prepared they perceive providers to be able to serve certain groups. The gray columns reflect providers' perception of their own preparedness. So over half of providers felt very prepared to support people who identify as people of color, 65%, and people who identify as LGBTQ+, which is around 63%. 47% of people with lived experience felt that providers were very prepared, and 44% felt that they were somewhat prepared to serve people who identify as LGBTQ+. 53% of people with lived experience felt providers were very prepared, and 38% felt that they were somewhat prepared to serve people of color. Fewer than half of providers reported feeling very prepared to support people who use drugs. This was similar to the perception of people with lived experience. More than half of providers did not feel very prepared to serve people who are unhoused. People with lived experience agreed with this self-assessment, with 39% rating providers as very prepared and 41% rating them as somewhat prepared. Meanwhile, the largest shares of providers reported feeling not prepared at all to support people who speak languages other than English. People with lived experience agreed with this self-assessment. 31% felt that providers were not at all prepared to serve people who speak languages other than English, and 33% felt that they were somewhat prepared. All right, so now we'll move on to a summary of our needs assessment findings. So overall, there is a need for more mental health and substance use providers and facilities in general across Windham and Windsor counties, and for specific populations such as LGBTQ+, BIPOC, and youth. Addressing workforce capacity needs such as burnout, stress, and turnover will be important for organizations to keep at the forefront of their minds. There is a need for increased collaboration across providers, organizations, communities, and sectors. Providers need to be given the space and time for professional development, training, and coordinating care for their clients. Stigma and judgment persist, and communities need to engage with each other around education. Many people with lived experience are overwhelmed with managing their health care, and increasing mental health and harm reduction supports were identified as community priorities, and inadequate access to basic needs such as transportation, housing, and food often create additional barriers to care. All right, so I want to thank you all for joining for today's presentation. We're going to move on to our Q&A portion. And if you have any questions about today's presentation, or if you would like a copy of the recording or want to know more about our needs assessment, please feel free to contact me. My email address and my phone number are up on the screen, and I can also input those in the chat. Stop sharing.
Thanks so much, Allie. We're very happy to take questions in the chat or for folks to just jump in since it's not a huge group here today. And we'll also save the Q&A portion as part of the recording and the answers as well. Anna, go ahead.
Hi there. Great work, a lot of information. I'm not at all surprised with some of the results, but it's nice to see it, one level deeper. Two quick questions. One, I'm wondering if anything came up regarding eating disorders. Did that show up at all in your research?
I don't think that we had any specific qualitative. It was not a question that we asked specifically, I don't think. And I don't believe it came up. Some of the questions around what are you looking to receive for
Mhm.
mental health services. I don't think anything that specific came up. We did kind of shy away from specific diagnoses and it
Mhm.
like intentionally so and kind of differed to folks to kind of word things as they experience it, but I don't believe it came up on the provider survey or the
Okay, thanks. The other thing, and it may be too early to answer this, but have you thought yet about how you go the next step? Will you be implementing work groups or, in terms of integrating with the community agencies? I know George and Bob and Josh have plans to meet with some other organizations, and I think that's great, but I'm just wondering if you have had any specific thoughts yet in terms of what that next step might look like.
Sure. I mean, I think this is really the first step is to share
Yeah.
with our community partners and get some feedback from folks as to kind of how it resonates with what you all see in your organizations and where points of collaboration and coordination might be sparked. We have launched our care coordination program this fall, so those resources are available for us as HCRS to be able to coordinate better and more seamlessly with other providers. So as folks kind of look at this information and it gets out in the community and we talk to people and do a little bit more information gathering on where the overlaps are, we do have the capacity built in to do that. And Victoria Potter, who's here, is our new CCBHC director. So she's going to be working over the next 3 years of the grant on really the implementation phase of all of this information. And we'll be kind of out in the community with partnerships more so.
Thanks, Rosie. And hi, Anna. Very
Hi.
nice to meet you virtually. Just to play off of what Rosie just shared, she's exactly right with what my thinking is about really diving into this community needs assessment and taking out some tangible items that are actionable for us to work on at the community level. So I am really starting to do a deep dive into that, and we'll absolutely be following up with next steps shortly thereafter.
Great. Well, bravo. This is a lot of work and a very nice job. So congratulations to everybody. Good work.
Thank you. I do see a question in the chat from Susan. Did anything surprise you with these findings? Or any of the responses not what you expected to hear? I think similar to what Anna said, I think mostly it was validating by and large, as opposed to surprising. But I think some of the things that I found most interesting were that folks with lived experience ranked, someone to listen to me as the top need, even above support meeting my basic needs. And it really made me pause and think like, oh, of course, that makes sense. How can you help someone, or support someone to meet their basic needs if you aren't even really fully hearing them as a provider or a support person? And so I feel like that was perhaps just something that jumped out at me that I think is so critical for us to listen and respond to, and how we show up with folks and really listening to folks with lived experience and what the needs really are. And then the other piece that I think was worth noting is the questions where we had providers kind of rank themselves, and then folks with lived experience share their experiences of it. That I think by overall providers mostly rated themselves higher in terms of their level and ability to support certain populations, and those populations themselves seem to say, you know, maybe there's a little bit more work to do here. And so I think that's something that's important for us as we think about training and just how we approach health disparities in our community, to be very humble in our approach to that, and our learning process, and learning with each other and the communities that we serve. Yeah, I think that was a humbling response. But I would be curious to hear other people's answers to these questions, so I'll stop there. Yeah, Samia.
Thank you guys for this. I've been like eagerly anticipating the release of this data, so it's awesome.
Thanks for your patience.
It's really amazing. I was really struck by the desire and preference for more providers with lived experience and that share identities with clients. So I hope HCRS is really looking at that and sitting with it and thinking about ways to implement that particular piece. And I was also struck by I just saw the one statistic around youth services, but that feels like a place that there's a lot more to be kind of digging into. And those of you who are taking on the next piece of this, it feels important to be looking at that. And I'm happy to support any amount of engagement with youth, or trying to think about services that are tuned into the needs of youth, because I think they oftentimes get a little bit marginalized, even though that's not the intention. Just the surveys are more adult centric. So just want to name that.
Yeah, thanks, Samia. And a lot of our youth data came from a listening session, which is small. Listening sessions are not huge by nature, but I think that process was so important, to be able to connect with youth, being in a physical space, having pizza, having non sort of traditional type question, they're not filling out forms. I think they did a lot of big chart boards and kind of interactive pieces and things that included movement. And I'd love to see that on a bigger scale, because it was a small sample size. So I appreciate that feedback. Any other questions that folks have? I'll give a couple more, maybe another minute and a half for folks to think. I'm fine with silence. I went to a Quaker college. We sat in a lot of silence, but I know not everybody has that comfort level. But I'll let you all mull for another minute or two, and then we'll wrap up. Yeah, Anna. Oh, you're muted.
I'll just add one more thought. I'm sure you're probably all aware that hospitals have to do needs assessment every 3 years. And of course, in ours, mental health and substance misuse or use disorder came up not only this time, but the last 2 surveys as well. So it's been over a 9-year cycle that I've been working on that program. So just want to reiterate that, we have to, as a hospital, come up with some implementation strategies around that, and very much look forward to working together so we aren't duplicating effort. So thank you.
Great, thank you. Okay. Won't let you all suffer in silence too much longer.
Actually, quick question. So the recording, how will that be available? If we want to share it with community partners or be kind of collabing?
Sure. Yeah, so we will, I don't think we included too much extra stuff at the beginning. We started the recording after Allie and I's extensive conversation on Western Mass bakeries. So that should make the editing process a little bit easier. And but once we double check and make sure, we can turn it around and get it out pretty quick. And Alice Bradeen is our communications and marketing person. So anybody, if you would like copies of things, let me post her email in the chat. And then I think she's planning maybe to follow up. I know some folks even requested the recording who weren't able to be here ahead of time. So maybe we'll just send out a large email and let folks know when that's ready. We do also have a public facing version of the report. So obviously this is a short-ish presentation. The report is, I think, 50 to 60 pages long. So, you know, lots of good information, a lot more qualitative data, which I really encourage folks to look at, you know, people phrasing things in their own words and things like that. So that will all be available shortly. If you don't see anything land in your inbox in the next week or week and a half, feel free to reach out to Alice or Allie or myself, anybody from here, and George.
Well, yeah, definitely. I want to thank everyone for putting all the effort into it. I know Anna mentioned Bob. That was Bob Adcock, who runs Springfield Hospital, and Josh Dufresne from North Star. We're going to be coming together, but to really talk about collaboration and partnerships and so forth. Needless to say, there's many other tables and spaces and coalitions and opportunities to come together. And I think it's so important as we come together to make sure that the voices of the people we're serving, this isn't about me, well, it could be, but it's not about me, it's not about anyone here necessarily, specifically. I mean, it's really about, although maybe it is about us, ultimately it's about people that are receiving services, people who've had that lived experience, and having that voice be part of the planning and really considering what are the services that are going to make a difference. Those are ultimately the voices that count. And so I think it's really important. I think having this opportunity and having this feedback and really making sure that this is the focus is really critical as we move forward in developing whatever it is we will develop to support folks in our communities. So anyway, thank you.
Thanks so much, George. I just popped a few emails in the chat for questions about the recording and report and things like that. That can go to Alice. And then if folks are inspired around further community collaborations and partnerships, especially around CCBHC, feel free to reach out to Victoria and Allie. And if you have any more data questions, Allie is definitely the person who can answer them. So thank you all so much for being here, and we look forward to continuing our work together. Have a great afternoon. Thanks.
Thank you all.
Thank you.